Thank you. Thanks, Joe. You guys want to stand up and stretch? Oh my God. Too much information going into your brains all at once. Can't be good. Good. Raise your hands above your head. Lean back. Good. I didn't think anyone was going to do it. Good. All right. Good for you. All right. Okay, as you're getting settled down, I'll try to get through this. So this is something very different. This is, I think Joe's point was perfect, is that, the key thing is we could talk about therapies and we could even talk about aging, but the real thing we've got to do is find folks who could benefit from these medicines and benefit from us even thinking about how to get people to live with HIV into their golden years. So unfortunately, there's still some people out there. We'll never get to 100%, but we should get as close as we can to identifying folks who are out there who don't know that they're infected so that we can get them into care. And people who've fallen out of care is another important area. So I'm going to talk about something a little different, and that's for the folks who are already in care. And many of us have heard about or are concerned about, and certainly our patients are concerned about aging with HIV. And I have to be honest with you, and those of you who've heard me talk about this before, not surprising to some of you who know me, is I take a somewhat contrarian view to the whole aging and inflammation and HIV sort of mythology, if you will, or party line. And I'll point that out. So this may, if there were 100 people who could be asked to give this talk, only a handful would give this particular talk. And I see the glass as mostly full and not empty. Others don't. So that caveat. All right. So this is what I'm talking about. In the media, and our patients see this all the time. Many of you care for people, know that this is a concern, and you have this concern yourselves, is that people with HIV are, quote unquote, growing older faster with accelerated aging, and they face more problems as they get older, and I think that's true. I'm not so sure the first statement's true, but I think this one is definitely so. And this scares people, and my patients are scared oftentimes by this, and I try to kind of talk them off the bridge and say, don't worry about it, it's not as bad as you think. And I'm going to lay out to you my rationale and some things you should think about. So some of the talk is geared towards you, and some of it is the messaging that I try to share with people when I get them in a room like this and it's full of people living with HIV or my own patients. In addition, some of what I'm talking about is applicable to anyone, regardless of if you're HIV positive or not. So there's stuff in here that basically increases your odds of living longer no matter who you are. All right, so let's talk about aging. Aging is really complex, and any one paper that gets out there and says, we found that there's a link between X and aging, I would take with a grain of salt. It's a very, very complicated process. It's a process that starts probably even before we're born and continues onward. And lots of things happen, and it's dictated by many, many different things, as you know well, by our genetics, by concomitant diseases that we pick up along the way, by our lifestyle choices, and by our environment, some of which we could control and some of which we can't. So while aging is clearly inevitable, the course of aging can be influenced by actions. So there's the stuff we can change, and there's the stuff we can't change, and I'm basically focusing on the stuff you can change because the stuff you can't change, so why talk about it? So what about facts about aging with HIV? It's pretty much the same. People with HIV, however, now have life expectancies that are very close to that of people without HIV. So that's really, I could stop right there. I mean, so you can read a lot and hear about, there's going to be lots more heart attacks, there's lots more strokes, there's more cancers, whatever. Regardless, whether that's true or not, people are living longer and now living basically within a hair's breadth of people without HIV. So if all that's true and my patients walking into clinic are ticking time bombs, I'm not seeing it, and the data are not showing it. Clearly, though, and I think this is going to be a really important point and a distinction to make, people with HIV definitely are at greater risk for a lot of conditions we associate with aging. So that's not arguable. I'm going to show you data. It's definitely true. There are more of these comorbidities. I think the question is, what do they do to? And this is what this is getting at. I think that this is open for debate. I don't think we understand this. I don't think this is an open and shut case. I don't think necessarily that HIV itself or HIV medicines speed up the aging clock and are responsible for all these heart attacks, all these strokes, all these cancers, all these things that people are talking about, brittle bones, et cetera, that occur in people with HIV. So we'll talk about that more in a second. So again, for people who are HIV infected, aging is inevitable. And the course of aging still can be influenced by actions. It's not a fait accompli, I have HIV, so there's nothing I can do. I'm going to have accelerated aging, and I'm going to have a horrible life. I don't think that's the case. There are things that we can do to increase the odds in our favor. So here's one of many slides that anyone can show about life expectancy, and we know that there's parity, both here in this study in Europe and here in the United States, and I think that's great. And we see it across the spectrum of age here. And again, it may not be exactly overlapping, but it's getting darn close, and I think that's wonderful. And this is an important issue, as you know, because while we concentrate appropriately on young men and their risk for acquiring HIV, and many of our new cases are almost exclusively among young men, there's still those of us who deal with patients, of course, the vast majority of whom have been infected for a while, and many, many of whom are over age 50 years of age and older. And so many of us are taking care of patients in their 60s and 70s at least. And that's projected, and you've seen these kind of things, that over half the people with HIV will be greater than age 50 by now, and in some parts of the country this has already happened. So living longer, living into your 50s, 60s, 70s, and 80s and beyond is happening, and something we have to just understand more about. So as I mentioned, there are a number of conditions that are more common in people with HIV, and some of them are listed here. And when you look at data comparing HIV negative and HIV positive people, and I'll show you a couple of slides on this, it's definitely far and away. So HIV positive are in red, so whether you're looking at many of these things, hypertension or cardiovascular disease, COPD, certain cancers, fractures, even diabetes, you see more people with HIV. Now again, I want to, you look at this and you say, oh my God, look what HIV does. And I really want to make sure we understand that that is not what this slide shows. What this slide shows is that people with HIV have more of these things happen to them. It doesn't say why. It doesn't point to the causation, right? So there's an association, but not necessarily causation. That's not to say HIV isn't playing a role in one or more of these things, but you can't say that it is, and that there may be other things. I don't think necessarily HIV directly causes COPD. Now, there may be things that HIV does to the lung, and there may be things that it does to the macrophages in the lung. I give you that, but it's a good example when we talk about smoking, which is the number one cause, and number two and number three and number five cause of COPD in anyone. So if there's more smokers in the red bars, you're going to see more COPD. That's called confounding, and there's confounding for each of these and in every study, and we try to minimize confounding, but it's really, really hard to do, especially when we don't understand what's going on and what causes something. That's a little bit of the theme for this part. So here's another good example. Here's acute MI, so acute heart attacks in HIV-positive people versus HIV-uninfected people, and as you can see, there's differences with HIV-positive people on top in blue, and HIV-uninfected in gold. And as people get older, you see more of the difference between the two. And there's other studies I could show that look at the same thing. But again, there's imbalances between the two groups. Even in this cohort that's somewhat homogeneous because it's gay men, it's living in urban areas, but there's other things that we see. And in this case, it's the VAX cohorts. These are veterans. Same thing for the MAX cohort, same thing that we've seen in the DAD study. But again, there's differences between the positives and negatives, whether it be smoking, and you can try to correct for that, but it's not always easy to correct for, and we don't often correct for something like quantity of smoking, or all the years of smoking, or other lifestyle changes. So it's really hard to do these comparisons because you can't find a perfect control group. Not every HIV-positive person has an HIV-negative identical twin who has the same sort of lifestyle. Same thing for actors. So here again, we're seeing data from the Veterans Administration and from others, and we can see, again, this is from a big group from Boston as well, that there's more fractures. But there's more glucocorticoid use, and there's lower BMI, and all sorts of other things that happen to people with HIV that can explain at least part of this. So I think we have to just, again, be careful when we start thinking and telling our patients it's their HIV that's driving this, when there may be other things that are contributing at least. And this is a really good example, and this is something that Joe points out all the time and that I like to think about and I try to formulate with my patients. We talk about statistics, and oftentimes we show summary slides. So this is not everybody who is contributing data. This is a curve that was generated to kind of smooth the data. But every individual patient, if I showed you, it would look like spaghetti all over the place, right? Some people had increases in fracture, some people had decreases in fracture, and we take the average. When you start looking more granularly at the data, in this case, looking at people who are HIV negative, HIV positive people in two groups that are on HIV therapy and suppressed, and HIV negative, HIV positive not on therapy with high viral load, and looking at a marker of immune activation, which could be linked to inflammation. Yeah, I mean, the story here, if I was writing this paper, would be, compared to HIV negative people, even people on HIV therapy with a suppressed viral load have higher levels, than HIV negative people. It's certainly lower than the people who are not on therapy with viremia, so it's gone down, but it's still above. But you know what? What if this is my patient, Bill, and this is my patient, Sandy? They're down here. And boy, there's an HIV negative guy, and he's all the way out here. So there's lots of overlap. My patients look at these kind of data when you only see the summary, and they say, well, I must be here. But they could be anywhere. So there's lots of overlap. And I think when we generalize, when we tell everybody that you're going to be up here, when really there's a lot of people up down here, and some folks here are dragging everyone up, it helps you understand some of the data better and interpret it. It's not a foregone conclusion that if you're HIV positive and on therapy and have a suppressed viral load, that you're going to have a higher level of this particular marker. There's increased odds that you would. There's a tendency that you would. But there's plenty of folks down here who are in certainly the range that these HIV negative folks are. All right, so let's talk about some specifics. All right, so what do we do about all this aging? Well, no matter what it's caused by, okay? So, I'm older, what do I got to do? One, as Joe pointed out by talking about the START study, starting therapy earlier makes a tremendously big difference. So, people can talk about, well, whether or not it's the HIV therapy or not. HIV therapy's benefits trump any sort of issues that we've been dealing with. And so we saw from the START study, I'm not going to go over it again, but Christopher Hurt made this beautiful graphic, it's hard not to show it, of starting therapy early versus starting therapy late in people with higher CD4 cell counts. You guys know the design. It's a really, really important study that Joe, again, pointed out its significance. And we did it here at UNC, and Greensboro did it as well. There's lots of folks who contributed. And as was pointed out before, not only was it clear when you start looking at many of the endpoints we cared about, but even for endpoints such as non-HIV-related outcomes, we see that there was a benefit. So, the composite and then age-related and non-age-related, definite benefit of starting ART early. So which people is HIV therapy good for? It's for anyone with HIV. All right. So cardiovascular disease, and I think this is the one that people worry the most about. Number one is start therapy early. Number two, stop smoking. Our patients have done a good job, and we've done a much better job of addressing smoking, but still, instead of being 3 times the rate in the general population, it's probably still double the rate. So my patients come in, they're worried about all sorts of things, but they're still smoking. This is a really tough problem. It's a really intractable problem for a lot of our folks, but it's hard to look at some of the data that we're seeing and ignore smoking. And it's hard to give a lot of the messages or worry about which antiretroviral you're going to use because you're worried about potential risk of cardiovascular disease from that antiretroviral, but the person's smoking. So these are data, again, it's hard to get up-to-date data about this, but HIV-positive people versus the US general population, the smoking rate is much higher, and it persists throughout different age groups. So generally about 20% of the general population smokes compared to HIV-positive people where it's 60% or more. And again, there's not really a lot of data that look at quantity, how many packs per day, pack years. Marijuana smoking is not captured in any of the studies that I'm going to show you. So I don't know, we don't know what that really does, but one can imagine that inhaling, flammable substances is not good for your cardiovascular system. In the MACs, the VA, DAD, no one looks at that. So again, there's these confounders that are measured and some that aren't measured that make it hard to compare. All right, so we know that it's bad, and some of the slides that I show, are geared towards patients, and I talk to patients all the time. It's also important to note that there are some pretty decent data that show that, and this is where there is probably a role of HIV playing some contributing, role in making things worse, that even with the same general amount of smoking history in HIV positive versus HIV negative, it looks like it's worse in HIV positive people. Maybe because they're doing more crack, or maybe they're doing more marijuana or whatever, or living more in cities, whatever it is. But it does seem that HIV positive people suffer more from the effects of smoke when you look at a whole bunch of different outcomes than people who are HIV negative with the same smoking history. All right, so it's not only smoking though, and I think that again, we know that there's more alcohol use, there's more non-injection drug use, and there's more injection drug use among HIV positive patients. And again, I think that these things lead into some of the things we're talking about. Hard to talk about differences between HIV positive and HIV negative people with neurocognitive, when we're talking about neurocognitive function, when you've got these things in the mix, and aren't always easy to measure. If we can't even figure out how many pills our patients are taking between visits, how do we figure out how much crystal meth they use between visits? So again, for me, the good news is I don't see a ticking time bomb. I see that cardiovascular disease right here, you can see it in kind of this bluish, is actually decreasing in most of the cohorts that have looked at it, and this is a European cohort largely. So over time, we're seeing it at least stable, if not decrease. So again, if they're ticking time bombs, they should be exploding all over the place. And I love these data from Kaiser Permanente out in California. Now it's California. California is different than the rest of the country in many ways. They may eat more nuts and more avocados, and they may do yoga. But the good news is that when you look over time, MI rates and stroke rates, again, parity between HIV positive and HIV negative people who are in a managed healthcare system in California. And they attribute this to starting HIV therapy earlier, using lipid-lowering medications, applying aspirin, getting people to stop smoking, like the normal stuff. They didn't give them a monoclonal antibody. So diabetes is another thing, and we can't ignore that because it's a real driver of cardiovascular disease, and many of our patients, especially where we live, have diabetes. And so really, this is something we try to stress, and we're working harder now with some of our trainees to think more about lifestyle modification, how to do a better job with diabetes, because for many of our patients, we are the primary care provider, and weight loss is clearly key for glycemic control. Trying to teach my patients that like their CD4 and viral load, which I've been trying to beat into their head for the last 20 years, they should know their hemoglobin A1C. Take their medications prescribed. I think non-adherence to diabetes medicine is even a bigger problem in some ways than what we see with HIV medicines. And doing the usual things, which can easily fall off of my checklist, like yearly diabetic foot exams, getting people to take off their shoes could be a hassle, but we should do it. Eye exams, testing renal function, which we do anyhow in lipid profiles. So what do we do for those people who are sort of in the pre-diabetic? And there are some of you who are primary care providers here who know much more about this than I do. But again, it has a lot to do with weight and increasing exercise and getting screened. And good news is we do glucoses all the time in our patients. But I try to impress upon my patients that there's some data behind this. This is not just all made up. And the other thing is that they don't have to go and send away to Amazon and spend $20 on a book to figure out what to do. That it's pretty practical, and that just some exercise, even modest exercise 3 times a week can make a big difference. And there are studies to support this outside of HIV. So here's a diabetes prevention program, 150 minutes per week of exercise and some caloric restriction. I'll talk about that in a second. And the goal was to lose about 7% of your weight, which is ambitious. But when they did do that, there was a 58% reduction in the incidence of diabetes versus the placebo group. And so, what does that take? So cutting 500 calories per day from your diet will decrease your weight by 1 to 2 pounds per week. So even if you don't do 500 calories, but do 250, that means it's going to be probably a half to 1 pound per week, which is pretty significant over a few weeks. So portion sizes and then empty calories. So this is common to many of you. There's some of it out in the hallway. right? So this is 240 calories just right there. So 2 of these a day, cut that out. So in my clinic, we talk about, the get rid of soda. Cakes and cookies and candy are for special occasions. There's no recommended daily allowance for any of those that you can find. You're having cake, it should be your birthday, your anniversary. That these are special occasion type things. You can already lose weight. It doesn't take anything really, really tremendously special. And so here again, cutting out 500 calories per day over 8 weeks. This is in obese people by BMI. The effect on weight is seen here. And we talk so much about inflammation. Oh, inflammation this, inflammation that. My patients have a high IL-6. They're going to have a high D-dimer. Inflammation went down by losing weight, just by cutting out calories. There was no statins given to these people, nothing special other than cutting out calories and shedding some of the pounds. And so a lot of these slides now from here on are from Todd Brown, who's a wonderful endocrinologist and a friend to people with HIV all over. And he talks a lot about this and how we have a distortion, not only in our body images, but in our food images. And so you can see here that this is what you're served nowadays, and the calories add up. And this is what really one serving means. So the labeling is a little funky. Sometimes you see it's only 100 calories on that bag of chips, but there's 2.5 servings in the bag of chips. And it's 100 calories per serving. So you have to be really careful. And reading the labels is important. He also points out nicely that some of these things have gotten supersized. So a bagel 20 years ago and a bagel now, and the caloric differences are pretty impressive. And again, just cutting out 210 every day, you're a ½ pound per week. All right. So we know that this can work. Watching liquid calories. This is what I think I stress most to my patients. That stop drinking the highly caloric sodas and juices, even juices, because people don't appreciate that, and fruit drinks. Watch the simple sugars. Basically, fruits and vegetables. If it comes in my household, if I hear crinkling, I know someone's eating something unhealthy. So if it has one of these on it, it's probably not good for you. I mean, come on, right? So, something that doesn't have this on it and grows in the ground. So that my patients, I tell them free reign. As much as you want to eat of fruits and vegetables, go for it. Not dried fruits, because we're talking about we want something that has some, water in it that's going to fill you up and has some fiber. But grapes, watermelon, cantaloupe, whatever you want, you can do it. And we talk about how not to ruin the effect by the way you cook these things. But this works, and this is the foundation of the DASH diet, which was developed at Duke and has been studied and found to reduce people's weight. And I think you all know about the food pyramid. It's like not what we do. This is the Mediterranean food pyramid, but this is what we should do, and try to concentrate more on this and much, much, much less on this. And using olive oil, and I think you guys know that. And we also talk in my clinic a lot about the plate method, and we've had this up on some of our walls until the sticky stuff in the back falls off and it falls down. But that your plate, if you have a large plate, really half of it should be the vegetables and fruit type stuff, and only a quarter should be your protein and a quarter should be your starch. And just trying to talk a little bit about what your plates look like, because it's usually the inverse. And I don't expect my patients to do this, or any of us to do this every single time. The idea is to tend to do this more than we do now, and more than the alternative. Okay. So Mediterranean diet, again, not hard. You just look at it on Wikipedia, and you know everything you need to know. It's not rocket science. You don't have to buy a book or go to a 12-step program. It does reduce new onset diabetes. I mean, it does work. Okay. And we talked about this and doing fitness type stuff. Again, this is mostly for others. I'm a big anti-elevator and escalator kind of guy. I look at stairs and I think that's free. It's a free workout. Just do it. And I'll talk to you more about why that's important when we come to frailty. But really, these are our enemies, escalators and stairs. If it's 3 stories or less, you should walk the stairs. So know your risk as well. And I think this is important. And we all understand the importance of knowing your CD4 cell count, your viral load. Most of us don't understand our risk of cardiovascular disease, even though there's some pretty good algorithms for figuring that out. Most of you are familiar with the Framingham calculator, which is pretty straightforward. Many of us got really kind of good and savvy on this, and it looks at basically your non-HDL cholesterol, and if you're a smoker, and your blood pressure. And diabetes was off this because diabetes was considered already an equivalent, meaning it's just as bad as if you had had a heart attack. And now there's a little bit different tool called the ASCVD by the American Heart Association, American College of Cardiology. It's a little bit different. It's a little bit funkier algorithm. Diabetes is included. Race is included, which is nice. And I think this is useful, and I've started using this a lot. It still sometimes gives me a surprising result. But what it's nice about is it gives you this calculated risk for 10 years, but also the lifetime risk, which is helpful because it's fine to look at 10 years. I might have a 35-year-old, and I calculate his risk, and it's pretty low, but his lifetime risk looks pretty high based upon his smoking or his high blood pressure or both. So this is downloadable. It's also an app on your phone. And it's really, really easy to use. And then there's even interpretation that helps you understand whether or not you should do anything like an intervention, like a statin. So how well do these things work? Well, here's the Framingham that I showed you first, and here's the cardiovascular risk calculator that I just showed you. And in people with HIV, if you look at a cohort that you follow for a while and look at do they really have heart attacks and strokes or not, it underpredicts. So they're not perfect. And I think that's probably true in a lot of different settings, but certainly within HIV. So any number you get is probably a little bit of an underestimate of someone's risk. So if it's on the cusp for an intervention, we might think about, well, maybe I'll do the intervention even if they don't meet criteria. And what about our drugs? And so Joe talked a lot about this, and I think it's important that we do have thought a lot over the last couple of decades about HIV therapies and their effects on lipids. And the good news is we have more and more drugs that are at this end of the spectrum. We know that TDF, tenofovir diprodoxyl fumarate, probably lowers LDL, which is pretty bizarre, whereas these drugs are more neutral. And then you get over here with the boosters, whether it be ritonavir or Cobi, where we see a greater effect on lipids, especially triglycerides. All right. Cancer. This is a really big issue because I think this is what many of our patients are dying from or suffering from. And the good news is a lot of the AIDS-related cancers have started to decline over the last decade or more. And that's wonderful. That's better control over viremia. That's better preservation of CD4 cells because CD4 cells help surveil for cancer cells, not just for infection. A lot of these cancers are virally mediated, and so getting control over the immune system is really important. But there are other cancers that we've talked about, like lung cancer due to smoking, and there's other cancers that maybe just even having a modestly decreased CD4 cell count puts you at risk for, like Hodgkin's lymphoma. And then there's others where there's really not clear evidence that HIV plays a role at all. And again, there's confounding that goes through all of this. We know that cervical cancer and anal cancer are on the rise. These are HPV-mediated cancers, so that's not too surprising. So cancer prevention, we talked about a lot of this, but starting meds early, that goes into that column in the START study. It protects you against certain cancers. Stop smoking, of course. And then there's surveillance and screening, and so pap smears, and we know that there's recommendations for that, mammograms as well, and some of these have been recently updated, colon cancer. So mammograms and colon cancer screening are really, really important, and they're underutilized, especially in populations of color. And so really getting people to do this, there's been a huge effort by the state to roll this out. And our patients come up with every excuse possible not to do these things. And we just have to really keep pushing them to do it. If people are hepatitis B or C positive, if they have cirrhosis present, they should screen for hepatocellular carcinoma. And I know Suzanne Nagy will talk about this. And then I think this is important too, especially down here, is that we do use some sunscreen. My patients really come in all the time. Many of them really, tanned or burnt even in the summertime especially. And I do worry about melanoma. We've had a few cases in our clinic in my patients already. And then preventing cancer also can be done by vaccination. So we know about HPV vaccination and also hepatitis B vaccination. What about anal pap smears? We had a good session on this a couple of years ago. Can't say that there's a whole lot of new data that we can share about this. In general, anal pap smears, just like cervical pap smears, sound like a really good idea. But there's really not what I would call crystal clear data that this is far and away an evidence-based intervention that we should do and that saves many lives and makes it worthwhile. There's debate about this, and there are many people in this room that would call me an ignorant slut and say that that's not true. You need a good surgeon. If you're going to do this, you can't do it in isolation. It kind of takes a village to do an anal pap smear. You need a good surgeon to follow up on the abnormal results and to have high-resolution anoscopy in order to do that. And some people here, Peter Leone and others, are becoming their own good surgeons, and they're being able to look at this very carefully and become experts. And I think that's appropriate as we get more and more of a deep bench of people who can deal with the problems, then it tips it more towards doing it. And then there's treatments for dysplasia for precancerous lesions, but unfortunately they're not fun, and recurrence is common despite treatment. So again, this is sort of a contrarian view. I think we have a ways to go. There are people out there who would strenuously argue that this is all wrong and that I will be proven wrong and that we'll save lives. And right now, I'm trying to save tushies, but I think that there's a balance here. And I just want to make sure we don't go down like the PSA prostate cancer rabbit hole, although that's also changing. So I just think we don't know. There is a study going on called the Anchor study that we may participate in that is going to answer this question. And so I'm doing this wholeheartedly in the hopes that it could contribute to that study once we start it up. All right, so cancer screening. Okay, kidney disease, we're rounding home stretch. We all know that kidney problems are pretty common in people with HIV, and there's a lot of reasons for that. There's a lot of risk factors for kidney problems in people with HIV, including the diabetes we talked about, high blood pressure, untreated HIV, HIV, and the kidney. The kidney does not like having HIV, and we see this. And every one of us who've looked at this have had cases of people who had moderate renal impairment who started on HIV therapy, no matter what you started them on, even TDF, and their creatinine went down because we were treating the virus that was inside their kidney and doing things, or the inflammation that was being generated by the viral replication that was also hurting the kidneys. We do know that certain antiretrovirals, and particularly like we've talked about is TDF, can have effects on the kidney as well. Generally, this is subclinical and in some small proportion of people clinical, but by and large, our drugs are renally safe in the doses that we use them, and we monitor this really carefully. I think the bigger issue, again, there's always something else that we're not necessarily paying attention to, but that's breathing down our neck, are things like NSAIDs. I think that a significant proportion of my patients who have elevated creatinines have it because they're taking nonsteroidal anti-inflammatories. And when I see a big bump in creatinine, I'm not so much worried that it's their TDF. The first question I ask them when I call them is, are you taking Goody powder or BC powder or Advil or Motrin or whatever? And half the time they say yes because they had some problem and I didn't know about it. And when they get off of it, things get better. So there are other nephrotoxins out there besides HIV medicines. And people should get screened, and we do a really good job of this. And I think HIV has benefited tremendously from understanding more about renal problems, and we're doing more and more than I think most people expect. And I tell patients all the time that they should know about this and they should understand their kidneys and what a creatinine is if they can, because problems found early can lead to interventions like ACE inhibitors or others that can help preserve kidney function. Joe already showed this, and I think it is important that there is probably some subclinical proteinuria that's been occurring in patients on TDF, here indicated in Stribild, and that people who are on TAF, the newer version of tenofovir, a newer delivery system, we don't see that. So I think that's good news, and I think we're going to see more and more people gravitating towards TAF instead of TDF for that reason. So be nice to your kidneys. Lastly, I think is bone disease. And I like this slide a lot. I stole it from Michael Yin a few years ago, and it shows you, this is all hypothesized, but that people, as we age, our peak bone mass is right in our 20s. Like so many things, after that, it starts to decline. This is not a slide of wisdom. This is a slide of bone density, not lessons learned. So for men, we see this decline, which is understandable, and then for women, even more so, but both. And I think that's why we have to pay attention to both men and women. And it's hypothesized that for HIV-positive men and women, we may see even deeper declines, and I think that probably makes sense. And again, it's multifactorial. So for bone health, we do know that people with HIV tend to have less dense bones than people without HIV. That's true. But again, there's many factors. Is it HIV itself or HIV meds, maybe like TDF? But we do know that there are other things that can affect the bone. And we have some really great, interesting, compelling data when we start looking at people starting PrEP. So these are young men, by and large, who've been studied, who are gay, who wear skinny jeans, and if you do a DEXA scan on them, lo and behold, they have low bone density. They're not HIV infected, and this is before they started on PrEP. And what is associated with that? Well, crystal meth, smoking, alcohol, low weight, and for HIV, prednisone, because many of our patients get prednisone for whatever reason. So again, this is a population that we tend to study, people with HIV, that already are enriched with many of the risk factors for low bone density. That makes it hard for me to say, oh, well, it's the retrovirus itself that's doing this. Bone density can be assessed. DEXA scan is sort of the gold standard. It's an X-ray. I'll show it to you in a second. This is part of an X-ray of that and looks at bone density using a computer algorithm. And then just like there's a Framingham risk and a CVD risk score for cardiovascular disease, there is a similar sort of tool that could be used, but it doesn't work very well. So let's see. I'm going to skip that. So this is what a DEXA scan does. So if you look at the bone density here of the trabecular bone, basic standard deviations compared to an idealized perfect bone density of a young person is what we're looking at. So when someone says that you have a bone DEXA scan or a DEXA scan that's negative 1.5, we're talking about negative 1.5 standard deviations away from optimal. So it's not normal, really. It's optimal. And so if you're 80 years old and you have optimal, you're superhuman. You shouldn't have that. You should be down here. It's not comparing you to other 80-year-olds, because then you'd all look normal, but you'd have bad bones. It's comparing you to an idealized, perfect bone. And as we get down to negative 2.5 standard deviations, now it's osteoporosis. Before that, it's osteopenia. This is completely all made up many years ago by a bunch of guys in a room. And it's been used ever since. All right, so how do you avoid getting osteoporosis? Well, we do know that vitamin D is important, and it helps you with your getting calcium into your bones, and so getting enough vitamin D is important. So while I think sunscreen's great, a little bit of, you want to do it on your face, you can keep your arms. Basically, vitamin D experts say 15 minutes a day of sun exposure should do it for you, but that's not where we get most of our vitamin D. It's a mixture of that plus our dietary, so it's a lot of where we get it from. You need calcium in your diet, and that's where dairy products come in. Weight-bearing exercises or hammering exercises, like when you run or do that kind of stuff, it helps a lot. And then this is a little controversial, but getting a bone density test once you reach age 50 for both men and women, if you're HIV positive, has been recommended by Todd and others. And people who have fallen or you worry about falling and can get a fracture, people have had an atraumatic fracture. So I have patients who say, well, I got out of my truck and I broke my ankle, or I had a very minor hit and I broke my wrist. Those are the people I really worry about mostly, and I get a DEXA scan. And then again, smoking cessation is an important part of this. So it'd be nice, you can have bone assessed and check. I am trying to check vitamin D levels very frequently, not frequently in my patient, but frequently in my clinic. I'm trying to do it once a year, and if it's normal, great, then I back off, but if it's not, then supplement and recheck, and I think that's important. All right, so what is this all about? The bottom line is what we're trying to do is prevent frailty, and if you look at people with HIV, the factors that lead to people having frailty, and you can kind of define this in a bunch of different ways, but these are people who aren't able to function the way that they should. It's higher when you have some of these comorbidities. So if you have an unhealthy weight, you're much more likely, if you're HIV positive, to be frail, or sort of even on the spectrum of frailty. Certainly if you have psychiatric disease, neurologic disease, diabetes, these things make sense. Even viral hepatitis. And that's probably because it's a marker of something else. These things are not completely in silos. So that's what we want to avoid. We all want to be functional as we get older. So I love this. Again, this is from Todd Brown, and I think about this every day. So here's a cross-section, right? So a scan through a 40-year-old person's thigh. Okay, so here's the bone, and here's the meat, and here's the subcutaneous tissue, right? The fat and the skin. So this is a healthy 40-year-old, right? This is a typical 70-year-old, and we call this sarcopenia, meaning there's a lack of muscle. There's an absence of muscle. Here there's lots of muscle, the marbled stuff. Here there's very little. You can imagine what this person looks like and how they would look walking across the stage. Pretty slow, pretty frail. So this is a 66-year-old runner, okay? And this is a 76-year-old farmer. I want to be like this, okay? The reason you want to be like this and not like this is that when you're like this, you can get up out of a chair. right? You could get off the toilet. You can go into the bathtub. These are things you can do. This guy's still farming. This guy's still running. Maybe someone's skiing. So this guy is not skiing. So you want to be like this. And these are the things we're talking about. So even in the New York Times, or in the journals the other day, there was, the 60-second, you could do 60 seconds of interval training and get the same fitness as somebody who did a much longer workout, a half-an-hour workout. Cardiovascularly and fitness-wise, I could believe that, according to what these researchers said, but their muscles are not going to look like this. And there's more to fitness than just having a good heart. It's an important part of it, really important part of it, but you're going to need to also have the muscle mass and the strength. Another study that probably got some press about a year ago is handshake. So people whose handshakes are firmer live longer. And it's not that their hands are getting to live longer, it's that it's a marker for strength, for overall strength, and for doing more. So I think those are the things to keep in mind as we all age and as we talk to our patients. So there are other comorbidities that I'm not talking about. We certainly know many of our patients live with pain, and that's a very difficult thing, and there's a session later on today talking about this. Loss of muscle mass, sometimes that's driven by androgen deficiency, so checking for that is important, but oftentimes also by not exercising, even just simple exercise. You don't have to use weights. Now more and more we're learning that you could do squats, push-ups, things like that. They're just as good. Neurocognitive dysfunction, again, another fraud area. It's very confounded. More of our patients have closed head trauma. More of our patients have depression. Very hard thing to study. More of our patients have depression, and many are socially isolated in all sorts of ways. And these are all worthy of full hour-long talks, and we have to pay attention to this and assess for it when we can. I do want to put a plug in for a study, and so this is the REPRIEVE study, and you might hear about this throughout the day. This is a study that's trying to understand more of that axis between inflammation, regardless of what it's caused by, and things like cardiovascular disease and other outcomes too. And it is looking at a pretty simple intervention, which is a statin. Statins are really incredible drugs in many different ways. We don't really understand them very well. But the nice thing about this study is it's randomized to people getting a statin versus not, and following them for many years for all sorts of different outcomes. And it's like 5,000 people. So they're going to get a lot of data no matter what. And I think they've done a really good job of making a study that's very doable, that dovetails nicely with clinical visits. So this is a study we're all in for at UNC, and I think other sites are too. And so I'm not saying that you're going to necessarily send your patient to us to get on a statin, but I do think it's a really important study and that you'll hear more about, and it's a pretty easy study for many of our folks. All right, so overall, people living with HIV have a higher risk for certain health problems. Check, totally agree. But many of these problems can be prevented or even reversed, I think, by actions that you take in your recommendations to patients, and also by what the patient themselves do. It takes work and encouragement. None of this is easy, and it has to be persistent, and we know that that's hard, and motivation is important. There may be some residual inflammation in people who are on HIV therapy, and it may play a role in aging, but I think it's really hard to say, and it's confounded. And interventions to reduce this residual inflammation are being studied, and whether or not they'll make a difference or not is something that we'll have to see. So overall, I think growing old is not easy, but I always tell my patients it beats the alternative. Okay, any questions?